Thank you very much, Del, and good afternoon, everyone. So I am presenting on behalf of my colleagues from the University of Sierra Leone and also Queen Margaret University in the UK. And we're working on the FCDO-funded ReBUILD for Resilience project. So ReBUILD for Resilience is all about generating evidence to improve policy and practice in fragile and shock-prone settings. In Sierra Leone, it has been in operation since 2012. So that was the first phase, and this is the second phase. And the approach that we've always used is to engage in research that speaks to a national need, because as you know, Sierra Leone, we've faced repeated shocks in recent years, and we want to ensure that we are providing the evidence to support that health system strengthening phase. And a bit of the context in Sierra Leone. So as we know, COVID, Ebola, in response to those shocks, we've always set up response structures at national and district level. So where the district is more or less copying what happens at the national level. And at the district level, there has been a reliance on traditional structures. And one of the main things that came out of the Ebola study was this issue of trust, where because of the setting, fragile, conflict affected, there's a level of mistrust between service users and the health system as well. So we've designed a study taking all of that into consideration. And also another FCDO study started just before the COVID outbreak, and it did a quick study, and one of the key findings from that, so that was the MAINTAIN study, highlighted the role of traditional leaders in supporting disease response, but they also highlighted the fact that it was not very gendered. So taking all of that into consideration, we came up with this study, which is community leaders' engagement to prepare and respond to shocks, increase inclusivity, accountability, and trust in support of health systems strengthening, health systems resilience in Sierra Leone. So community engagement, as we know, is recognized as core to resilient health systems. Engaging with communities and the leaders, ensuring that you incorporate their views into emergency responses and health system strengthening interventions is key. And that ensures that there's dialogue at local level. It promotes accountability and trust, and all of this should be done through the inclusivity lens, so ensuring that the vulnerable groups and the disabled groups, the women, are also included in this process. So the aim of this study was to provide insights into the current community engagement strategies in response to public health emergencies and health system strengthening interventions in Sierra Leone through an inclusivity and accountability lens, and test approaches to support and improve engagement to develop resilience capacities in the health system. And we've got three specific objectives. So first, to map and understand who are the community leaders in relation to their role in the health sector, and then co-develop an action agenda and a plan for system strengthening with the local stakeholders, and then to observe and assess the implementation of the action agenda and reflect on the process. So what are the challenges and what are the opportunities there? And we've used participatory action research, which we've divided into phases, and it's a research cycle where we first map the current situation. So that would be phase 0 and phase 1. So phase 0 is a document review. What do we know already, published literature, grey literature, on the role of community engagement in the face of a shock in Sierra Leone? And then phase 1, again, which is also speaking to mapping the current situation, is where we did 3 workshops. So this is where we undertook power mapping of the different stakeholders. So these 3 workshops, we divided the stakeholders identified at community level into formal, informal, and community. So formal, the section chiefs, traditional healers, the Mami Queen, so these are the women leaders, and also the DHMT. Informal, the religious leaders, the Market Women Association, and then community members would be other members of the community. So once we've mapped out the current situation, then we have, so in terms of what currently obtains and what are the power dynamics in terms of the community leaders, and then we try to identify the leverage points. And this was phase 2 of the study, where we have 4 workshops, where workshop 1 is where we try to identify what are the problems, so root cause analysis. And then we do a Venn diagram. and then develop an action agenda and also a pathway to change. And then once we've done that, we have a pathway to change. So we've co-created this with the community members. So this supports ownership at that level, and it also supports sustainability, because what we have done, so at the district level, health activities are mediated by the district health management teams. So before we started this process, we engaged with the DHMTs, so they're headed by the district medical officers, explained the cycle, and asked them to serve as the institutional base. Because when we leave, all of the learnings from this could be institutionalized within the DHMTs, and they'll be able to take this forward, so it will be sustained. So once we've done that, we've identified the problems, we've come up with a pathway to change, then we implement. And I must say at this point, we are at phase 2. We're currently planning for phase 3, which is where we implement the pathway to change. And in implementing the pathway to change, we're not reinventing the wheel. We're implementing using the existing plans at the district level. So how can we further support what they had planned anyway, but then use the evidence that what we have found out from this process to support that. And then once we implement, so that will be a 12-month cycle, then during which we'll reflect and document the process. It also provides a platform for adaptation and learning. And then we're also thinking at the end of it, as I mentioned earlier, it's a cycle. We can then start the whole process again, hopefully in the same districts. So what are the key findings that are coming out? So from the document review, the key lessons that came out to inform future strategies in the face of a shock or everyday resilience. So I'm not going to go through all of this in the interest of time, but cross-learning. So EVD, so what was documented in the literature was that the learnings from EVD helped inform the response to COVID. And then there's also this issue of gender and inclusivity. So we have a very strong theme of gender equity, social justice, and inclusion running through ReBUILD. So what the document review is telling us is that gender is core to community engagement. So therefore, barriers to women's involvement in community engagement and social mobilization should be addressed. And this links back to studies, to evidence that we had generated from ReBUILD phase 1. So therefore, we should ensure that the responses, future responses, should ensure that there's inclusion of marginalized and vulnerable groups. And then also regular updates, feedback, and adaptation of the process, so there should be continuous follow-up visits to the communities, and it should create a two-way dialogue platform, so communication is key. Program integration through a multi-sectorial lens. Community engagement structure should go beyond pandemic preparedness and response, so this will ensure that we're proactive as opposed to being reactive. There should be clearly defined protocols and measures to collect data. So community engagement scale-up should involve clearly defined protocols to facilitate sustained relationships between the response activities, frontline health workers, and the communities. And they should also put measures in place to promote real-time data collection and analysis that can inform the response decisions in real time. Sufficient funding, that goes without saying, to ensure that it's sustainable in terms of community engagement. So that's from the document review. So now from the research itself, the power mapping. So phase 1, as I mentioned, where we try to do the power mapping to identify the most representative and influential leaders at community level, their power relations, understand their powers and roles in relation to the health sector, and power and trust, and how this changes over time. And the findings from this will inform who we involve in the next phases of the study. So what is coming out? So these are the two districts, Kailahun and Moyamba, very different in terms of context. So these are the different actors that they've identified, and also they've also classified them according to high trust, medium trust, and low trust. So green high, yellow medium, and red low trust. So this is for Kailahun district, where you see those in the middle there, so the district health management team, the media, NGOs, the traditional leaders, social mobilization. These are all classified as high level of trust. And then if you come to Moyamba, again, more or less the same actors been classified, but then what really stands out is traditional healers. So they've said traditional healers, low level of trust. But if you look here for Kailahun, Traditional healers, medium level of trust. And this goes back to the context. So it's been said repeatedly, context is key. Kailahun is a district that's very much accustomed to traditional healers. So that's why you'd imagine that they would classify them as medium level of trust. But then Moyamba, not so much. But then we know that the reality, for example, in the face of Ebola, usually the first point of call when dealing with something that we do not understand in these districts is traditional healers. But then they're being classified here as low level of trust. And then phase 2, where we identify the problems. So we asked both the stakeholders that we were engaging with to use a reference point. In Kailahun, they use maternal and child health, and in Moyamba, infectious disease. And the key things that they came up with as barriers that can impede effective community engagement: political affiliation, where we're very much, we have a two political parties, and we're very much what's the word? Committed to them. So once you say you support one, whatever happens, you support them. So that can affect how the barriers to community engagement, because you can approach someone, but then if they're affiliated to another political party, often they think that disease outbreak shocks are linked back to politics. Traditional beliefs that came out quite strongly during Ebola. The media, social media, could be used for good and also a force for evil, where you can spread false information. Poor community engagement, absence of focal persons at community level, and that links to reductions in the number of community health workers. Shifting trust in the health system. During Ebola, health workers were not trusted. Gender norms, and then in terms of access, in terms of the terrain. So phase 2, where we've asked them so we map the actors and also ask them who's important. So they've classified these in levels in order of most important, important, and less important. And this is for one of the districts, Kailahun. I'm not going to go through that, but then what comes out is that traditional healers, so it goes back to the point that I made earlier. So this is a quote: essential to community engagement, and they can engage communities to refer cases to the formal health system, so they're paramount. And then we also, so the final step of phase 2 was to come up with this pathway to change. So we've co-created this pathway to change, taking into account the problems that we've identified, and this is what they think could be done to address the problems within their district. So phase 3 now will involve, I'm going to skip through this. I was just going to talk about how this links to the conceptual framework within ReBUILD. But the next steps is where we identify linkages. So as I said earlier, we're not reinventing the wheel. So trying to map out who are the actors in the district that are already doing work that links to the pathway to change. So we've identified in Kailahun Partners in Health and another local NGO, Focus 1000. There's an early warning system in Kailahun district. At the national level, there are thematic working groups being set up at the Ministry of Health, focusing on community engagement and health security and emergency that we're linking with. And then we're planning for phase 3, where we meet with the DHMT and the relevant partners, so these that I've mentioned here, and we come up with what we can implement during phase 3, and then we monitor, and at the end of it all, we conduct key informant interviews. So what have we learned so far? Ownership and sustainability is key. We've also discovered that within the DHMT that we're working with, a lot of those who are working there are volunteers. So how will this be sustained? We're engaging with them, we're building capacity, but then if an opportunity comes up, they will have to leave. So these are some of the risks that we're working with. So unintended consequences, power dynamics, and then most importantly, context is key in what we're doing. Thank you.
Thank you.